Hello.
Oh, there she is. Hi, Kate.
Hi. Yeah, I'm sorry. I'm having a really difficult time with my audio here. I had to call in with my phone. I couldn't do it on my computer.
I couldn't do it either. I'm not sure if something was happening on the back end.
Yes, so I apologize. For starting this just a couple minutes late. Good afternoon, everyone. This is Kate Cohn-Parrott, and I'm pleased today to be moderating this conversation on meeting the mental health needs of frontline employees fighting COVID-19. I'm the president and CEO of the Greater Detroit Area Health Council, and we have a really nice mix of representatives with us today from a variety of health systems, Henry Ford Health System, Ascension Health, and St. Mary Mercy Livonia. Do you want to move the slide ahead, please? Great. So just a couple background slides on GDAC. For those who don't know, we are a regional healthcare improvement collaborative, or what we call as a RIC. We serve as Southeast Michigan's trusted healthcare convener. For those of you who don't know, a RIC is a cross-sector, multi-stakeholder, nonprofit membership organization. We serve Michigan's Prosperity Region 10, which is Wayne County, Oakland, and Macomb counties, and Wayne County includes Detroit, and we are dedicated to improving health and healthcare delivery. Next slide, please. Okay, this slide is busy. I'm not going to go through it. It's a great slide, though it has a lot of great information. It basically gives you our vision and our mission, which our mission is together with our partners. Remember, we're a membership organization. We empower and improve the health and economic vitality of individuals, organizations, and communities by catalyzing the power of collaboration. And we are, if you look through this document, later, it talks about our core values and our goals and gives you some of our strategies. Next slide, please. Yeah, so this one is pretty heavy duty, but it's a very important slide because it identifies what we think are some of the problems, some of the issues in healthcare delivery that we are working to address. And what's very important about that is that we have to come together and do these, together. So if you look at the far right, and I'm not going to go through all these again, but we are wasting limited resources across the community with duplicative initiatives that compete to solve population health challenges that are better addressed collaboratively. There you go. That's just give you one kind of an idea of one of the problems that we're trying to solve. Next slide, please. And this slide, I love this slide. It highlights who we work with, who our partners are: providers, physicians, hospitals, and others, health systems, payers, health plans, insurers, purchasers, and employers, and patients. And then it's our job to bring them all together here at a common table. And on the right-hand side, this highlights a little bit of some of our efforts. So we're not going to get into that, but again, these materials will be provided to all of you, and so you'll have a good opportunity to look at that later. And we welcome questions as well. And guess what? We're all in this. We all did this together. Whatever the problems are, it's easy to say, "Well, I didn't play a role in that," but we all did. We all played a role in whatever these issues and problems are, and so we all have a role in trying to fix it. So how do we come together, and how do we, address that together collectively? So Again, a lot of background information here, and we don't have time to go through it all. Unfortunately, I'd like to spend a lot of time going through our what GDAC does, but we're going to move on because we have more important things to talk about right now. Next slide, Nikki. Okay, here's our agenda today. We have Brenda Blaka, I hope I pronounced that right, Selina Schmidt, and Nicholas Nicolopoulos. And so let me give you a brief bio on all of our speakers. Brenda is in charge of employee assistance and wellness for Henry Ford Health System. She's the manager of their enhanced EAP and wellness program, has been in the field of EAP and wellness since 1995 with a myriad of clinical experience, both in chemical dependency and mental health. Further, Brenda has a vast history as both an account manager and professional development trainer and coach, presenting to a wide audience of folks on topics such as thriving on change, stress management, work-life balance, effective communications, team building, dealing with challenging situations, avoiding compassion fatigue, and leading for success, and many others. Brenda has a bachelor's and a master's degree, both from Wayne State University. She has a certification as a substance abuse professional, a certified employee assistance professional, certified health and wellness coach, and level 2 certified Reiki, oh, I love that, practitioner. She's also served with the military as a top secret security telecommunications operator for the United States Army stationed in Stuttgart, Germany. Additionally, she has an extensive array of volunteer experience, including being a team member for local outreach to survivors of suicide and a team leader for the Macomb Emergency Response Group, providing critical incident response. She also has enhanced her skill set by being a facilitator for skills for managing anger and systematic training for effective parenting, among others. Brenda balances work life by spending most of her free time with her husband, 2 teenagers, and extended family and friends. She enjoys all sports with volleyball, baseball, basketball, bicycle, and hiking as her favorites. She also enjoys gardening, cooking, traveling, reading, and practicing mindfulness. I'll go ahead and just do the bios for everyone, and then we'll move forward. Lina Schmidt is the Director of Behavioral Health Service Lines at Ascension, Michigan. Selina's responsibilities include overseeing the behavioral health services for the entire state, consisting of acute care hospitals, outpatient clinics, and substance abuse services. In addition, she has over 15 years of working with the mentally ill at all levels of care. Selina volunteers and advocates for the mentally ill at the local, state, and national levels. Currently, she is a board member for Macomb for Individuals with Mental Illness Committee. She recently was appointed to the Michigan Hospital Association and assigned to the Integration of Care and Medical Clearance Committee for the state of Michigan. Selina received her psychiatric mental health nurse practitioner degree from Wayne State University and her undergraduate nursing degree from Oakland University. She also obtained a Master in Law degree from Loyola in Chicago with a focus on healthcare law and policy. Nicholas Nicolopoulos is the Chief Nursing Officer and Vice President of Patient Care Services at St. Mary Mercy Livonia, where he served as the Director of 8 medical units at St. Joseph Mercy Oakland, where he managed more than 500 colleagues and had 100 direct reports. Following a 4-year tour of service as a U.S. Army medic, Nick joined St. Joe's Oakland in 1995 as an emergency room team assistant. He became a nurse assistant in the intensive care unit and critical care pool and advanced to manager of the ICU. He earned his bachelor's degree in nursing at Oakland University and a Master of Business Administration degree in healthcare management from Western Governors University. So you can see we have a very illustrious panel with us today, and we're excited to hear them speak. So without further ado, Brenda, I'm going to turn this over to you.
Can everyone hear me okay? Yes? Okay,
Yeah.
I see. I don't hear anyone, but I see some heads shaking. So thank you for inviting me here today, and good afternoon to all. I'm excited to be able to share some slides with you and to also hear from the other panelists, and a couple of questions that I was asked to answer today and to provide information on as what we've done at Henry Ford Health System to help our employees through this pandemic was to share any particular tools that we had found that were beneficial and helpful, to provide the statistics of usage on that, which I can share with you, to talk about some of the practices that we may keep in place moving forward, to talk about how we were able to keep morale up during that time, which of course was challenging, and then maybe what are some of the positives that came out of the epidemic. So that's what I'm going to do in the next 10 or 15 minutes here. So we have put together, so what we're referring to the plan that we have in place now is our Recover and Heal plan. And those are the strategies that we've really put into place within the last month or so to help not only our frontline workers, because there was a lot of focus in the beginning on, those that were coming to work every day and actually dealing with the COVID patients and helping them. But it was also the entire healthcare system, obviously. We have 34,000 employees here at Henry Ford Health System, and each employee was impacted in a different way, and we had to make sure that all the strategies that we had in place would be helpful to each different person in their unique situation. So one of the quotes that we used in our Recover and Heal program is, "As the pressure to act releases, the pressure to feel intensifies." And that's where we're really wrapping our energy right now, because what we found in the early days is that our nurses and those that were furloughed into the COVID units, they really were doing just an awesome job coming to work every day and adjusting to all that was going on and working with the patients themselves and dealing with all the things that were going on. And they were doing that day after day after day after day after day, and we were finding that there wasn't a lot of feelings being expressed. And as crisis responders, we anticipated that, and we knew that, and we knew that those feelings would start to surface more when we started to see a little bit of settling. So healthcare workers are well trained to manage the intensity of a medical crisis, but they're not equally trained in managing its mental health aftermath in themselves and others. So we've really been focusing our energies on helping our employees deal with the mental health aspect of the pandemic. So through from crisis through recovery, so crisis in the early stages and recovering now, supporting our teams using psychological safety is what we've done. So ironically, the tools and resources that we put in place right from the beginning are the very same tools and resources that we're using today to help our employees in a different way. And I'm going to get into that a little bit deeper, but that is psychological first aid. So I'm going to talk about the reasons why it's so very important. We helped our team members really recognize stress reactions and distress, not only in themselves, but in other team members. A lot of energy went into helping our leaders help our employees, and then really helping employees recognize the importance of self-care and of role modeling that. So the next slide talks about a basic and easy to learn intervention, and that is the psychological first aid. So psychological first aid is a compassionate, supportive, and practical assistance to help individuals who have been recently exposed to a stressor. And I hate even to use the word stressor because it's so much more than just a stressor. But really the primary role is to listen actively, to help normalize and validate people's feelings and reactions, and to provide comfort and to provide resources. So psychological first aid was our primary method of intervention during the crisis mode, and it continues to be during what we're referring to as our path forward. The next slide just gives a little visual. I'm not going to go through all of this, but really it shows what the different components of the psychological first aid. And I'm sorry, did you say that you would be providing the participants with these slides after the webinar? Did I hear you say that, Nikki? Or somebody said that?
Yes, this is Kate. I did say that. That's
you did say that.
typically what we do.
Okay, great, wonderful. So it just helps me decide how much detail to go in. But really what we want to do with the whole psychological first aid is we want to assess needs and concerns. We want to be non-judgmental. We want to be curious. We want to ask questions. We want to listen. But there's obviously no pressure to talk. Sometimes just being with the person is what they need, providing comfort to them, answering the questions that we can answer, maintaining a sense of calm ourselves so that we can help de-escalate the situation and keep people calm in the moment, and to normalize and validate feelings while also helping to link to resources. So while we were going through this, we were certainly linking our employees to resources that were available outside of Henry Ford Health System, but we also put together a vast array of resources that were available internally. So step one on the next slide for psychological first aid is really to promote safety. So if you think of anyone that's ever taken a psychology class, which I'm sure many of you have, you're familiar with Maslow and Maslow's hierarchy of needs. And basically, you know, if we don't have our basic needs met, if we don't have food and shelter and we don't feel safe, we're not able to really function at a level any higher than that. So as we know, when this pandemic was first hitting us, there was a sense of, am I safe or not? Many of us did not feel safe. Many of us still do not feel safe. The fear, the anxiety, and just all the unknowns were there. So our first goal was to really help promote safety. And we did that by listening, validating feelings, showing respect, and doing that as often as we needed. Step two is to promote connectedness with colleagues and family. So we really work together with our teams to support one another. You know, as we know, everybody scrambled and started working remotely and working from home. So we had a mix of those that were still coming to work every day, along with a mix of those that were working from home. So how do we do that, and how do we help our leaders and our managers support our teams remotely when they've never had to do that before? So, you know, how do we do that? And then how do we do that when we can't even see our family members, especially for those that were coming to work every day and being exposed to COVID? They couldn't go home to their family members. So, you know, we're asking our employees to come to work and to deal with this population and put their own safety at risk, and then we're putting them in hotels because they couldn't go home to their families and risk exposure to their families. So just a really, you know, a really tough time. So we really wanted to promote connectedness as much as we could, ask them what they need, and make referrals as we went along. And we're doing that now. So now as we're, you know, starting to bring people back to work, and we're reopening our ambulatories, and we're starting to do surgeries again, and we're encouraging people to come back to the hospital and back to our clinics. First of all, that's one of the safest places to be right now. You're safer going into a clinic and having an elective surgery than you are going to a bar or a restaurant because of everything that we have in place. So we have been pleasantly surprised at how open people have been to coming back to the hospital for care. Step three, and I know I'm going to go through these really quickly because of time, but step three is to really help facilitate function. So by being courteous and compassionate and empathic, we were able to do that early on, and now we're doing it again now as we help the population adjust to their new normal. Step four is to help the person may feel and act as if they have no control over their lives. And gosh, I'm sure many of you on this call, I'm sure all of you on this call had a sense of feeling out of control, and what is this all about, and what are we going to do, and you know, what's it going to look like, and you know, and then it changes. So what we're told in the morning to do might change by the time the afternoon came. So really just helping people have a sense of control as much as they could within the situation that they were in, teaching them resiliency and trying to promote a sense of normalness as much as we could. The next slide just talks about some of the emotional reactions that we may have. So, fear and terror and depression and shame and regret and guilt. And, for us in EAP, especially doing the clinical work that we do, we were finding that those that were already struggling with some mental health disorders, or they were having, substance use misuse, domestic violence, all those kinds of things, it was escalating to high volumes and a high magnitude. So really trying to address all of those things and deal with all these different feelings that were going on. And then the next slide talks about the importance of leaders. So we recognized very early on, and we still do recognize that it's really important to support our leaders, because our leaders were working really hard. I mean, we were easily putting in 80 hours a week, if not more. The days were all blending together. I mean, on Tuesday we thought it was Sunday. There wasn't any rhyme or reason any longer. And we were all scrambling to work really hard. So how do we support our leaders? How do we make sure that they stay healthy? How do we teach them the importance? We all know we need to put the oxygen mask on ourselves first, but how do we really make sure that not only do they have permission to do that, but that they're doing it so that they can role model that for others? The next slide is just another short picture that kind of shows some of the different reactions, cognitive, emotional, physical, and behavioral reactions that we were seeing from the beginning, and we're certainly seeing continue. Really budding people up with one another, and recognizing that if you see it in someone else, to feel safe enough to approach and to say, hey, I noticed this, and is there something I can do to support and help? So the last three slides in my last couple of minutes here talk about the resources that we put together for our Henry Ford population. Again, the first one is the psychological first aid class. So we made that available right from the beginning. Within the first 4 or 5 days, that very first weekend, we put that together and had it rolled out by that very first Monday. And it was a virtual training, and it was pushed out to all leaders. And we required all leaders to take the online course. And then as things started to settle more, we started providing that through Skype. So it was a little bit more interactive, and people could ask questions, and we had drop-ins that you could do, or you could schedule that for your department, and we would go into your department and do it. We also developed several different grief and loss support groups. We had 4 or 5 different varieties of those at different days, different times, even getting up at 1:30 in the morning to run support groups, so that we had that available for our shift workers as well. Peer processing groups, that's probably our most popular right now. And what the peer processing support group is we bring a mental health professional into a department or a team, and we actually, and we process feelings. So it gets a little bit clinical, a little bit therapeutic, more than just educational. And we're really processing feelings and talking about how we're impacted, what's been the hardest, what we've learned. We get into personal things. What was hardest for me is I've got small children at home, or whatever it is that the group wants to talk about. They have a safe and confidential way of doing that. Conversations with leaders was another tool that we had, and we offered that 3 times a week, every day at 12:15, so that leaders could just call in using Zoom, I think that was. We had all different kinds of platforms, and they could call in and just have conversations with other leaders across the system to talk about their unique challenges as a leader. We also have a trust program that's a one-on-one peer support program for our providers, so it's available for our physicians. So we know at Henry Ford that when we, it's always hard to lose a patient, obviously, but for a physician who's been the primary provider for that person, there's a unique need to help that physician debrief and talk about that. So we connect them with a peer who can have that conversation with them. Spiritual care was also very important. We have, of course, spiritual care leaders across the system, so connecting people in that aspect was something else that we did. Of course, we have our employee assistance program on the next slide, which is my department. We've always had EAP. We will always have EAP. You have to have an employee assistance program in place to truly help, and definitely in times like this, very, very, very important. We have, within our EAP, we have a dedicated person that works just with our physicians. All of our EAP therapists can work with physicians, but we have one dedicated person that works with the majority of them. So we provided her information and reminded people that she was available. We have work-life services, which we've always had, but we made sure that we promoted that because of childcare needs and financial. Of course, people were losing their income, and there was a lot of financial needs and worries about that. So we were able to connect them with those resources as well. We have a crisis response team, so we were able to go in and meet with teams when we did have a loss, which, of course, there was way too many losses, which was the hardest part. When people ask what was the hardest part, I have to say for our frontline workers, the hardest part was just the magnitude of death. It's not typical to have 4 patients or 5 patients die in one 12-hour shift, but that's what we had. And it was just a very, very, very scary time. And still is. We still have COVID positive patients in the hospital, and we are still dealing with it. It seems like, society, a part of society has forgotten and has moved on, but it's still here, and it's still real, and it's still something that we need to keep first and foremost in mind. Substance abuse treatment was another resource that we needed to put in place quickly because we had people that were at risk for relapsing, or people that really weren't struggling with substance abuse prior to this, but found that they were using that as a coping mechanism. So we put some peer recovery coaches in place to help with that. So my last slide talks about our greatest takeaway, and the greatest takeaway, I would say, and this is just my words, is together we are strong. We can and we did conquer a pandemic. I know we're still dealing with it, but obviously we're dealing with it in a different capacity right now. And we did it, and we did it together. And the massive outreach and support from within, I could not keep up, especially in the early stages. I could not keep up with the phone calls that were coming in of people wanting to help. How can I come to EAP, and how can I help you team? And I've got crisis response training, and I want it, and I can do trauma response, and how can I help? How can I help? How can I help? We eventually had to start saying no to donations of food because there was so much food being brought in for our workers that we were just overwhelmed. So the community really just embraced all of us, and we do have a long road ahead of us, but together we will heal. We will be stronger than ever. And then, C-19, it provided an opportunity for us to really pause, evaluate, and hit the reset at both an organizational level, but also at a personal level. So I know for me personally, and I'll end on this, I'm married, and we've been married for we celebrated our 22nd year during all of this. We have 2 teenagers. I have a 17-year-old and a young guy that just turned 14. I'm very grateful that my children were a little bit older and could be able to, make their own meals during all this, because I certainly wasn't around to be able to do that for them. But I know that my relationship with them, we have had more family dinners in the last, 6 or 8 weeks than we've probably had in the last 6 or 8 months. So for that, at a personal level, it caused me to pause and to be able to really assess my life and, with all that busyness and craziness, what I want moving forward, or do I want a more settled life that, maybe I do want to stay home more. I've actually enjoyed staying at home a little bit more, and will continue to do that. So for that, I am grateful. I put my contact information in here. I see that I am not a LMSE. I am a LMSW, so that's a typo in there. But my phone number is in there, and my email address is in there. Feel free to contact me at any time. I think we're opening up for questions at the end. Is that correct? Yep. Are we moving on to the next panelist?
Yep, we are. Sorry, this is Kate. I was talking, but I was on mute. So
okay.
Anyway, I appreciate your comments. That was really informative and very interesting and valuable. What I was started to say is your comment about your children being a little bit older is really, I think, germane. So when my husband and I were talking about that over the weekend, that how difficult it has to be for people with very young children and trying to work and trying to manage your kids and stuff. So it's awesome that employers are sympathetic to that. Thank you, Brenda. Now I'm pleased to introduce Selina Schmidt. We already did your bio, so Selina, I'm going to turn this over to you. Thank you.
Like your purchase both sides of my head, where the lighter one's easier. So I keep the heavier one and share my phone. I'm on it right now. I keep share my phone.
Nikki, are we able to get Selina on the call?
Can you hear me?
Yes, I can hear you now.
Okay. So I work for Ascension, Michigan, which is a very large organization nationwide. So when COVID hit us, I'm going to tell you a little bit of where we started and where we've ended up. Decisions were being made at a national level, which was not in the heart of the COVID epidemic. And so what we did is, can you put my slides up, Nikki? Thanks. To the next one. So, as a faith-based organization, we came out with this great statement, and we said, our mission and vision and values was inspired us to serve others in a compassionate and just way while we transformed healthcare. It is through the efforts of our associates that we bring our ministry to life. That is why we created new and unprecedented temporary pay and benefits offering to support our associates. And we were proud of that. But what we found, the next slide, please. What we found is that, yes, in the beginning of COVID, our associates, everything was stopping here in Southeast Michigan, and the decisions were being made outside of Southeast Michigan. And so what we did is we put these great things in place. And as I got brought into the hospitals and I was working in the emergency rooms and trying to sort through things, and I'm a psychiatric nurse practitioner, and I found that I was, intubating and trying to figure out what does it look like on the side. We had all these great things in place, but I started seeing things that really were beyond financial support. So, some of the things that we did, they were wonderful. They were supportive. They helped, that financial burden. Next slide, please. So what we saw is we put things in, and, we thought that if we could help them, we heard a lot of things, well, my husband lost his job, or my husband is, in the hospital, or my parents are in the hospital with COVID. We put together things like dependent care because, there was no school, there was no daycare. And, for 13 and under, or taking care of a parent, we were reimbursing for daycare. We had pay continuations. We, if you went out sick into, a quarantine, we were going to pay you. PTO advancements, you could take out extra money. If you were furloughed, we have 250 primary care offices where our associates now we're out of a job. And, for those that could come into the hospital, great, but others, could work remotely, others were furloughed, and we continue to pay them. For myself, which is a salary position, they were paying me beyond my 40 hours. And, so by the time I got done with my regular job and was working, on the front line, we were pretty much working, as, the other speaker spoke, we were working 60, 70, 80 hours a week. Next slide, please. So we started looking at, we were burning ourselves out. And fortunately for us, the majority of our hospitals in Michigan are not in the Southeast Detroit. Yes, we do have from Rochester to St. John all the way to the Providence system, but we were fortunate. We could pull in staff and PPE and resources from our northern or our western ministries, and we were bringing in a staff from other states with PPE. And so we were paying for the travel expenses so our frontline staff to take a day off. You know, we were paying for the 100% of the hotels for those that couldn't go home. You know, we took some of our philanthropy that was, you know, unrestricted and tried it back in. You know, COVID, internet access for those working at home. But after about the third week, the staff, this didn't really matter to them. This wasn't where we needed to be to support our staff, to get them what they needed to come back to work. Because yes, we fixed all these things, but what we found is the staff were starting to crumble. Next slide, Pete, please. So, you know, here's the dollar amounts we spent. And the staff came back at us when we had our first town hall, which was in the beginning of May, and it didn't impress them. Money did not impress them. That wasn't what they were looking for. They were looking for leadership. They were looking for people on the ground that they could speak to. Next slide, please. So we had to rethink what we were doing. We had to understand that as I was working on the floors, I saw staff that were agitated, that had no patience, that were uncharacteristically yelling. I had blank stares that would take that yelling and then walk into the next room. We had codes going off continuously. The largest supply we were getting from the supply room were body bags. Staff were complaining that they couldn't sleep. They were having, you know, virtual dreams. They were eating like a teenager, junk food. You know, joking around that they were having liquid dinners because they couldn't get to bed at night. You know, crying, just crying for no reason in the middle of the day. As humans, we need human contact. And during COVID, people were so bound up and so masked up, we didn't know who we were speaking to. Our new associate had no idea who they were talking to half of the time. And so we started, you know, by mid-April, we knew we were going to lose our associate. We needed to rethink what we were doing. And so I came out of the field and came back into my office, and we put together the associate wellness team across the state that actually went national. Next slide, please. So we put together our spiritual well-being, and they were daily prayers, reflection. You could call and you can do a prayer for somebody that would be announced overhead. You could do a personal prayer for yourself. Our chaplains were 24/7 in all of our hospitals. We had virtual prayer groups that went nationwide, so that you could connect with your peers and other health systems that were being affected. We had emotional and mental support. We had virtual peer support groups. We had an entire web page of just tools and videos to boost clinicians and associates mentally and emotionally, and cohort dialogue groups, which again, we use that psychological first aid, which is phenomenal for this type of work. We were able to connect to our national resources. So, you know, when we have states, you know, our health systems in 22 states, we had systems that weren't being as affected, which jumped in and helped us, because what we found was our leaders, their cup was so full. They were working nonstop. They were struggling. They, you know, were putting in 7 days a week, 16 hours a day, and they felt the burden of their associates. They would walk the hall and they would see the numbness. They would see the exhaustion. They, you know, were asking their associates to do things that they never did before. We were taking, you know, same-day surgery, and now all of a sudden they were an ICU nurse. We were taking a dietary person, and now all of a sudden they're an MHT on a suicidal patient. And so, you know, we really were asking our staff to do things that in a normal day we probably never would have asked. And that had such a heavy burden on our leaders. We started developing webinars that, you know, they could sign in, they could be part of it real and live and ask questions, or they could go back at any time they wanted to. Right now there's 30 different webinars. They're about 40 minutes long on every topic possible. that had to do with COVID or resiliency or self-compassion. Next slide, please. Of course, our EAP, wonderful. They were providing free virtual counseling. Our Eastwood clinics went completely virtual. Their IOP, their partial, their group therapies were all virtual. We converted their crisis line into a suicide prevention line for associates also that could reach out to them for immediate assistance. They were providing everything there, virtual support. You know, as I said, we had on-demand spiritual care therapy. We had on-demand psychiatrists for our associates and support groups. We have a large holistic nurse group at all of our hospitals in Southeast Michigan that took it upon themselves to do mini mindfulness sessions, anywhere from 5 to 15 minutes, that they would do several times a day across all the ministries, and that they could all jump on exactly at the same time, whether, you know, it was for morning meditation and centering, or a yoga session, or mindful minutes, which actually started off very slowly, but slowly gained, not just by the nurses, by every single associate. Next slide, please. But what we found the most beneficial is that the staff were concerned that if they attended some of these virtual things, if they did these, that they would break and they couldn't put themselves back together. And so what we found worked the best is we put together what we called our We Care teams. And they consist of social works, LPCs, and chaplains. We started with the executive leaders, and it's an in-person, confidential, open dialogue that has no scripting, no notes. They're just personal conversations. And we took it to them. They didn't have to call in. They didn't have to join through an email account or jump on a computer. We went to them where the trauma existed and where it began, and that was on their units. That was in the hospital. That was, you know, out of place on where they had lost control. They lost control at home. They lost control at work, and they had no control. They had no personal interaction, and the leaders couldn't assist their leaders or their, you know, managers or directors or their associates, because they had it so built up in themselves. So we started at the top, and we went through the entire hospital. It didn't matter if you were contract service. It didn't matter if you were, you know, a dietitian that just delivered trays, or the EVS, or our security, or somebody that processed medical records that never even had direct line care. Everybody had trauma that they didn't even know that they had trauma yet. And so what we did is that we worked with the associates and what their perception of the events were, not what ours were, not as leaders, because I know what we were doing behind the scenes. I was part of those decision making, and how, you know, they would weigh on our shoulders all day long. They didn't see that. What they saw was that the leaders were sitting behind a desk. What they saw was decisions were being made so rapidly that it almost looked like we didn't know what we were doing, but we were moving as fast as we could because things were changing on a daily basis. They felt like they were being put out and that they weren't being heard. You know, you're not a COVID unit. Yes, you're a COVID unit. We're going to convert you. You're going to get your PPE. No, there's not enough PPE, so you're going to wear it for a couple days. And so, you know, we sat with them and we let them process. We, you know, worked through what it was. We gave them some great exercises. We, you know, created trees at one of our sites where everybody could take a leaf and put things that they want to take forward post-COVID and things that they want to leave behind. And it turned into this ritual moment. And, you know, everybody kind of was like, yep, I remember that day, and I want to remember that day, and yep, we really want to do this. We elicited from our staff, what if you could sit down one-on-one with your leader at your hospital, what suggestion would you give them to make the changes going forward? What would you have them want to consider doing differently if this should ever happen again? And we put it in their lap to partner with executive leadership to take some of those great ideas that they had, that they felt nobody was listening to, and things that they would like to change. I think that between what they want to take forward and what they want to leave behind and suggestions of how to handle it has been some of the most cathartic things that we have done. People have done big collages in hallways so that the associates can see of what they want to go forward with. They've done the trees. They've created poems and songs. So as we did it, we worked with our managers. We created, special groups, cohort groups, because we were taking staff from areas that had never worked on a medical floor because they were same-day surgery or recovery. And the staff were like, well, you need to include them. They were there with us. And, some of the stories that I had to do my, how I process, I'm a shower crier because nobody would really know how it affected me. But some of the things like, I learned how to write backwards because I had to tell my associates that I needed just a few more minutes because I didn't want them to die alone. We heard these stories of how, I snuck my phone in there and I FaceTime so that, they could say goodbye to their loved one before they got vented because who knew if they were ever going to recover. The heartbreaking stories, I missed my little one's first steps because I can't be in the home with them right now. So, we're really looking at, it's a partnership with our associates right now, and they're at the table with us while we're making decisions, what processes we want to take forward, what processes we want to leave behind. Some of the things coming out that, one of the most positive things that they got is that we don't have, initials behind our names anymore. We are a group of associates that make decisions rapidly for the best interest of our patients. There's no doctors, there's no nurses, there's no respiratory therapists. We all came together. And all that bickering about communication and you should do this, and you did, it all went away. And so, we helped our staff understand the resiliency that they came to work every single day and kept doing what they wanted to do. And how they came together as a team, and those are the things that we're hearing that they want to bring forward. And our executive leadership are so proud and excited to begin partnering with with the associates. And the associates actually identified who they wanted to represent them. So it wasn't like a manager going, oh, you're really good at doing this and you're really good. It's the associates that kind of said, hey, you need to call this person because, she's really good at communicating, would be great to represent us. So that's how we've kind of, engaged. Can you go to the next slide, please? So we found out that financial assistance was really good, but it wasn't what our staff needed. We found out that, the high priority past COVID, which lasted a month, to decrease the work in their home life stress really wasn't what they needed. What they needed was that spiritual, that EAP, that peer, that virtual, that peer support. And the key thing for us is that really is engaging in that partnership with our associates, having them at the table when we're putting together our emergency plan for the next time something like this happens, and have them at the table to assist with them. Let them feel like they're really part of our system and that they have had a say and that they have been heard. And one of the other biggest takeaways is that these WeCare teams, the staff want them post-COVID because they love the idea of Ascension just wanting to be there for them, regardless of what event. Like up at our St. Mary's, that half of our associates lost their homes and they couldn't come in. So that was our chance here in Southeast Michigan to go up to our St. Mary's Hospital in Saginaw and replenish them and to assist them during that. And we learned our lesson in Southeast Michigan of what the associates really need. and that is that peer-to-peer support and being heard. So that is my presentation. Thank you.
Thank you. That was fascinating. Your stories are really tug on the heart. They're heart-rending. Can't even imagine how difficult this has been for people like you and people at the front line. So thank you for everything you've done. And now we will move to Nick, the Chief Nursing Officer at St. Mary Mercy Livonia and Vice President of Patient Care Services. Welcome, Nick.
Thank you very much. Thank you for having me today. Can everyone hear me okay? Perfect. Thank you for the nod. Thank you. And thank you to, all of you that are on the line and all your staff for, caring for our communities through this pandemic. It was not easy for, I don't think, any medical facility within, Michigan, especially Southeast Michigan, where we really got hit hard. So if you could just go to the next slide and the one after that, probably. I don't have a lot of slides, just one really. I just wanted to I got some bullet points and just kind of want to talk through our experience here at St. Mary's, who we are part of Trinity. So we're throughout the United States, and we have 5 hospitals here within Southeast Michigan, and we're one of the smaller ones. We're a 300-bed hospital, but only about 212 of those beds are for med surg and critical care. And at the peak of our surge in COVID, we had 182 COVID patients at one time. We had one unit that had no COVID patients, and that's all we had. We went from a 16-bed critical care unit to having 32 ICU patients on a ventilator. So we really had no, pre-COVID, no space for that. So, I can't say how impressed I am and proud of the response of not just the frontline staff that, I was working with, but our facilities department, who opened up our old emergency department that's been closed for years and put up a 10-bed ICU. We turned our step-down unit into another ICU. To the staff from our OR and other areas that used to work in the ICU and redeployed themselves and really helped us out. And so we were really hit hard. We were hit the hardest in Southeast Michigan, within Michigan Trinity. So amongst our sister hospitals, we were hit the hardest as far as how many patients we took care of. But we really managed it well, so I couldn't be more proud of that. Another thing I know was mentioned by one of the other speakers, that the rate of mortality was overwhelming. And the rate that our patients would decline, their respiratory status especially, was something I've never experienced in my 25 years in healthcare. It was overwhelmingly fast and hard to manage. So one thing that we did to help manage that and respond to that and help our staff is we created a comfort unit. We closed one of our units, which is a chemical dependency unit. We closed that and turned it into a comfort care unit. For all of our patients that were at their end of life, to be able to go to and have as much of a peaceful end to their life as possible. We staffed it with a physician that was, their specialty was palliative care and end of life. Also with palliative care nurses, so they really knew how to manage the end of life. And we used a lot of FaceTime. We deployed a lot of iPads so that our patients and their families could say those last goodbyes. So I think that was really meaningful. It took some of that burden for our units that weren't used to end of life, and really got the right people at the right time taking care of these patients. And like the speaker said earlier, it was overwhelming how many deaths we were experiencing through the peak of the COVID response. We're also lucky to be part of Trinity Health, and something we did to support our staff to increase. We increased our ratios. Normally, 1 to 4 to 5. Our COVID units, we try to get to a 1 to 3 ratio to manage those patients, and we were pretty successful in doing that. We had a lot of travelers. I know Ascension, I think, said the same thing. Travelers from New York and New Jersey and Iowa, and through our northern Michigan sites that weren't seeing the spike that we were, but we had around 50 travelers come here just to St. Mary's to help us out, and it was very well received. holding the COVID line, that's kind of how did we keep our staff's morale up, and how did we maintain the front lines caring for our patients. And it was really the first 2 weeks of our surge was probably the most challenging. One, trying to get enough PPE. Two, the acuity of the patients. And our rapid response rate and our code blues were probably doubled to tripled on a daily basis, and we're really having trouble managing that. So our physician groups, and we're primarily private physicians, non-employed, but they all came together with nursing, and we created geographical teams where we had a group, a lead physician that would take our residents and just take on a floor. They weren't scattered. They do geographical assignments, and they were here all day, 7 days a week, managing those patients on a daily basis, and they're on the floors as a resource to the nurses. So that was a tremendous value, and I always say, don't let a good crisis go to waste. But our rapid responses, our code blues, decreased immensely, and it still has to this day. And we are reorganizing our hospital to move towards geographical teams of physicians managing our patients on the floors. But we'll still have, opportunities for our private physicians to admit here, but we're going more towards a geographical assignment. So that is a learning that we took from this whole pandemic to move forward and improve our quality and patient care for the future. And one of the biggest things was the community. I know this was mentioned as well, but I can't go without saying Livonia was amazing. The community here was bringing us stuff every day. The drive-by car parades, honking their horns at shift change multiple times on a weekly basis was amazing. Our emergency services coming through and doing their drive-bys. We had around 12 communities that participated in coming through and showing their appreciation for our staff and the frontline staff. Also, I know this was mentioned too, but the staff were doing murals and posters in the hallways, and we kind of let go of, we don't want things on the walls. All that stuff kind of went out the window. Whatever we needed to do to keep their morale up, we made every effort that we could do. And on my side, something that I was really dedicated to was, one, being very transparent, one, being in the work with the staff. On a daily basis, I rounded every day on the units, answering questions, being transparent, let them know what's happening. I would attend a huddle every day to include the day and night shift of a unit, and just kind of go through any questions, their concerns, because they were scared. And as you know, as it was mentioned, information was changing on an hourly basis through that first few weeks. So we implemented a command center call at 10 a.m. and 4 o'clock p.m. every day during the week and on the weekends to go over any updates and changes, and that was open to all staff. And we also created weekly town halls virtually, and we opened up a Survey Monkey where staff could submit questions. And then on Fridays, all the senior leadership would come together and answer questions based on their areas of expertise. And at the peak of the COVID pandemic, we had around 400 people on the calls on Fridays, very well received. It helped keep people informed and answer questions that they had concerns about. And that's also something we're going to continue throughout moving forward. It won't be weekly. We're going to move to monthly, but we're going to also open that to all staff to submit questions and help move forward. Some learnings through the COVID pandemic. One was I don't think anyone could have been prepared, but as far as PPE and availability of PPE and how can we be more prepared if we were to have another surge this coming fall, winter time period. So we do have developed a PPE committee that's led by our frontline staff, nurses at the bedside, and we're developing a good process on how we can manage that moving forward, working the supply chain to have a good, stock of the supplies that we will need, and working through that. So that was another big learning that we have made coming through here, is just making sure we're prepared if this ever comes to fruition again. We're also, the support for our staff, we have an EAP program here, but you know, no one was willing to come on site. So we really felt that we needed people on site helping. So our behavioral health director and our pastoral care department started doing some resiliency rounding. And that is something we continue today, where they're going unit to unit, talking to staff, offering their services, and just getting those conversations going. And we're also working, I partnered with our residency program. We're going to do a research study on PTSD with all of our staff. So we're going to create a survey now, and then in another 12 months, we're going to redo that survey, because a lot of PTSD comes about around a year after the incident. So we're going to do that, and the staff is very responsive to that as well. So we continue to work daily. Also, I can't forget to mention my dyad partner, our chief medical officer, was always willing to come out with me and be at huddles to talk to our staff on a regular basis. We were out there every day together, talking to staff, answering questions, and just, I think, knowing that we were in the work with them, we were honest, transparent, and making sure that they had the correct amount of PPE, the right PPE, and just keeping them up to date as possible, which I know is a challenge for all of us as things changed from the CDC, from Trinity. You know, the guidance from Trinity was changing rapidly, so that was really a challenge. But you know, I couldn't be more proud of the staff, and I know we're already coming up on 2 o'clock, so I will stop there. But if there's any questions for me, I'll be happy to answer.
Thank you, Nick. That was great. Certainly a lot of things that we've learned in the last couple months. So I'm going to open this up, and I think we're having some type of problem with the audio if you're on the webinar. So please feel free to put your questions in the chat box, and then we will ask our panelists. So I appreciate if you would do that. So question for all three of you, and so maybe we'll just go Brenda, Selina, and Nick. And if this is kind of a loaded question, if you don't want to answer it, it's okay. But so I was up in the UP for a few days, kind of remote, not around people and whatever, but I went into a few stores and restaurants and a hotel, and nobody was wearing masks. I mean, even the wait staff in one of the restaurants, most of the restaurants, the wait staff had on masks, but I went into one and no one had on a mask except for my husband and I. And so I guess I'd like to know what your reaction is to that. Again, it's a loaded question, so feel free to not answer if you're not comfortable. Brenda?
Yeah, it's been a topic of conversation with me and my team and at Henry Ford a lot over the last week. And I know I said at the end of my presentation, COVID is still here. We still have people testing positive. We still have patients in our hospitals. And, you know, I said in the beginning of all of this, I wish that every person in the world could have spent one day inside the doors of our ED during this pandemic, just one, even just 3 or 4 hours, if they could have just been inside of our doors for just a day to see what was truly happening, I think we would see things differently now.
Yeah, good point. That's a really good point. Selina, what is your reaction to that?
Well, you know, I agree with that. I think that if you were not touched by it, then you do not understand the impact of it. And for those of us that heard the stories and had to make those really tough decisions that will change us for the rest of our lives, you aren't going to understand the need. I wear a mask, not really for me, but I wear it for other people. I don't know if I am that asymptomatic person. You know, we were in the hospital. My son was on a COVID unit working. He would come home and tell me that he, you know, 4 of his patients died tonight and 2 more went to the ICU, and he knows that they won't be there tomorrow. And that, you know, he couldn't even process it at the end of the day. So, you know, I tell everybody, you do you, I'll do me, but I will be the one that's taking care of you when something happens.
Good point. Good point. And my sister's a nurse, and she is working in the ICU. She doesn't normally work there, but she got pulled into the ICU on the COVID unit at Beaumont and Taylor. She's not there now. They moved her out, but yeah, I personally have a link to that from a family member. Nick, what is your reaction?
Yeah, I agree completely with the previous comments, and I think, you know, unless you've really experienced, you don't know what you don't know. And, you know, and I'm the same, I wear a mask when I'm out and about, and I'm not shy to ask someone why they're not wearing a mask, especially if they are, you know, doing a business to where they should be wearing masks. So, and wearing the mask completely, you know, half the time they're around their chin or something like that. So I'm not shy to just ask a question. And also, you know, we took a stance here to, if a patient is not willing to wear a mask as they come into the building, we're not going to provide those services unless it's in an emergency situation. But coming in for testing, we are, you know, if you're not willing to wear a mask, then we're not willing to really provide those services. But we haven't had to do that.
Yeah. No, but that's a good place to be. I think we have to be strong on this. I was, like I said, very surprised when the wait staff in the restaurant I went into the other night did not have on masks, because at least when I went places, the staff people did, except for that one place. So it was like, whoa, this is a little interesting.
Yeah.
I had somebody send me a note that they have some interest in the Ptsd research study, Nick, and I don't know if, you know, you can share more now, or maybe that's something we could explore, I think, on a subsequent maybe webinar.
Yeah.
Do you have any more comments on that? Because I did get a couple of notes on that.
Yeah, so our lead physician that's over the, works with the resident, it's going through the IRB right now. And they're developing the survey, and it'll probably be some sort of survey monkey or of some sort. And we're going to have some demographics, so we can, compare our male and female workers and ethnicity and age and all that stuff. And then also do a PTSD kind of questionnaire that they're going to develop. It will probably be a one that's been, tested already. And then we're going to offer it up to all staff and get the results, and then repeat in 12 months. So it's going through IRB. I don't see any issues of it getting through that. But yeah, if anyone wants to reach out to me, I'm more than willing to keep you updated on that.
Yeah, thank you. I think it sounds fascinating. So let me just go, I guess I'm going to go back at the top, Brenda, and then we'll go to Selina and Nick. What was your personal biggest surprise in everything that you learned? Or most valuable piece of information, let's say that.
I would say for me, some of the things that, for years we were saying that we should work more collaboratively with other departments, or, we should do this, and we should do this, and we should do this, and then this hit us and it forced us to do it. So, and we did it, and we did it really quick. I mean, I had my EAP team, all 30 of them, working at home virtually within less than a week. Had COVID not been here, it would have took months to do that. So lessons learned for me is that we can do things, and we can do them very efficiently, and we can do them more quickly than we probably think that we can. And we can do it right, because we did a lot of things right.
Oh, that's great. Thank you. Selina, for you?
I think the biggest thing that I saw come out of this is true, compassionate teamwork. In the past, you always have doctors and nurses, and you have, your patient, care assistants, and whatever we want to call them. There's the dietary, there's, the transporters. But during COVID, there were no titles. They were just people working alongside each other. Nobody cared what department you worked in previously. Nobody cared what your education level was. Nobody cared, what your beliefs were or what your skill set. People just said, you know what, I got that for you. Go take care of that. Or what can I help you with? Don't worry about me taking a break. I got you covered. I know that you've had a really tough day. I have never seen such wonderful collaboration, and it was so uplifting, no matter how dark our days were and how many tough decisions. When one associate lost a patient, everybody on that unit lost that patient, and they just picked up and kept on moving. The resiliency, it helped heal my heart at the end of the day, watching the staff do what they did every single day, no matter how tough it was.
Yeah, that's obviously very very nice to have been able to witness. I mean, obviously you wish that you wouldn't have had to witness it, but you know, and I think Nick mentioned earlier, you know, you can't waste a crisis. So the fact that we're able to leverage this and get on and, you know, do some positive things is at least a good outcome. So Nick, I don't know if I should be calling you Nick or Nicholas, so I'm sorry. I don't know what your preference is. I should have asked you in advance, but what is your biggest takeaway, most valuable lesson?
Yeah, you know, I agree. You know, I continue to be amazed at what we accomplished through this whole pandemic, and like you said, a whole hospital coming together, not just the hospital community. I mean, everyone rised up together to do what they had to do to take care of our patients, our community. I mean, building a new ICU in 2 days and having everything needed, you know, biomed department, facilities, everything. 2 days to stand up a nice area for our critical care patients. A comfort care unit, just it's amazing what you can come, you know, when you come together, what you can accomplish. And, you know, the biggest thing that's coming out of this for our hospital is our geographical teams and having our physicians come together that were, you know, private at one point, coming together to say, this provides the best quality and support for our patients. And we need to continue to do this. And how can we make it happen moving forward? The value that was found by physicians, patients, nurses, everyone loves it. Of course, we have some that don't, but you know, it's the direction we're going, and I think that's going to be one of the best things that comes out of this for St. Mary's and the community and our patients.
That's great. That's great. Well, we are out of time here. We appreciate your contributions. Thank you, Brenda. Excuse me, Selina and Nicholas, and thank you to Nikki for coordinating and organizing this. Nikki does a great job with that. We will distribute copies of the slides. So, you know, we're open to answer questions and respond to anything that everyone has subsequent to this. So thank you again, and I hope you all have a great week, and see you soon. Bye.
Stay safe, everyone.
Bye. Hi, everyone. Thank you.
Thank you.